to the last video or the last reflection video, and I feel so I'm confused. Really, I'm confused because sorry. My little light. Because I've never read so much in my life. I really have to investigate, to search online, to read a lot, like I never did. And I'm so happy. I feel like the purpose, the course is complete, and I'm unconscious. I really feel so happy, and even that I feel like I learned, I understand that the migration is a process not only for to move another country. It's more like a physical process and about the family, psychological, and health, because anybody thinks about that. When you move to another country, just for a stand or stay in your country, you have like a social service, like your medical, but when you move, don't you have it because you're not a native in that country. So what the people does in this case, and it's something that we got blind until we read about the process, and maybe I feel excited. I feel happy too because I reached to communicate my ideas in another language. English is a course everybody take in your high school, but I never think that really someday this is a tool for communicate in your job, in your school, or maybe you want to work in another country. It's like it's universal, and this was a challenge for me. It's an extensive vocabulary that I can't manage so well, and I learned to do it. Maybe it's a short vocabulary, some ideas that I want to express with you, but I try it. I try to learn. I try to learn new words for expansive my vocabulary, the past tenses, future tenses, and it is something incredible that I really did. I feel comfortable speaking in English, and this is whoa, amazing. And takes a long time to feel comfy, even when you know that you make mistakes, because I do, and maybe I'm doing it right now, but it doesn't matter because it's something incredible when you finally say, I can do it with my mistakes, but I can do it. Well, and we start with this reflection video, and I hope you enjoyed it. And let's talk about the migration entities and healthy equity. And the main points of the readings and the concept the authors is across all the articles. There are three. Is paradoxical decline of health among migrants upon prolonged residence in high-income countries. Like the phenomenon represents a major public health crisis where the benefits and initial healthy migrant effects are eroded eroded by the host country environment. And the core concept, the others can be as a migration experience followed by long duration of residence, is a powerful social determinant of health that drives up the burden of non-communicable diseases, particularly obesity and diabetes. This is chronic diseases in the Other Frank and Cunningham review specifically demonstrates a significant and positive relationship between duration of residence and the USA increase in body mass index. As you know, the USA got the first or second in the world of obesity. And Demontis, Eichmann, and Van den Born in this article would highlight that diabetes prevalence is constantly higher in virtually as migrant groups compared to the host populations, often with an earlier age of onset. I think this is because they consume fast food, junk food for their jobs like construction, and not a professional when you got a better food in your job, you have the ability to buy these products and the others, and the time you got the time specifically. So the others, they leading causes morbidity and mortality globally, and their recent prevalence of migrant and populations generates increasing clinical, administrative, and economic problems for national health systems. And this focus is crucial because it highlights a clear area where public health intervention, such as prevention programs and tailored to cultural and temporal needs, is both necessary and potentially highly effective. So the second, is there anything it wasn't clear? And what remains confusing is the differential outcome observed various entities. So what the authors here is something difficult to express, but I'll try it. They states that while diabetes is constantly higher in all migrant groups, the risk of other conditions such as a stroke, coronary heart diseases, this is the most common disease in the world that can conduce to die. Well, and overall cancer morbidity is highly dependent on the migrant group's country of origin and the country of settlement and specific chronic diseases. And the weight is not fully, it is like a point to a complex interplay of genetics, early life factors, and specific gene environment interactions that are not fully designated. Because this is like not all the people thinks about this, because when you know that your genetic it's no good for you, you have to take care more of your health. And why don't you? It's because don't you have time, don't you have the economic position for to do it. But always there a solution, even when you don't know to do it. You search someone to advise you and to give you information about how to do it. And a clearer path to understanding will require longitudinal research, cohort studies that track specific ethnic groups over time, and to isolate the causal mechanisms by which acculturation influences disease expression, and differently for different entities and different migrant populations. So the third question, what was new to me or changed my think or perceive I see the things, is the most transformative insight was provided by the Montesi in our paper. Oh, my little light. Once again, stay please. And which revealed that even in countries with universalistic healthcare systems, this is high-risk ethnic minorities with diabetes and is still significantly undertreated. And I have previously viewed universal access to this valid for health equity. And however, the adverse point of the undertreatment, it is not simply a matter of access, but it's a consequence of systematic barriers rooted in socioeconomic status, language issues, and the cultural intensity of the cultural biomedicine. Crucially, the paper states that its industrialization of primary care and the drugs is not cost effective. It is ultimately leads at higher hospitalization rates and greater economic costs due to advanced disease complications. That is a good point, because when you say I have not the money for the medicines, but trust me, it is the double the money that you can spend in the hospitalization that you can't spend in the medicines. So these realizations radically changed my perception. It confirms that equally in access does not guarantee equally in health outcomes. It compels me, as a future physician, to prioritize not just treating disease, but actively working to reduce structural barriers, practice cultural humility, and advocate for culturally adapted healthcare delivery models. It's not too difficult, but we can do it. And if there anything that I would like to explore further, I want to know more about and why, I would like to explore the Salmon bias. This is a hypothesis for here, and this hypothesis suggests that the apparently better health is lower mortality rates observed in same long-term migrant groups, because this is the healthy migrant paradox. It's like artifact caused by sick or failed migrants returning to their home countries to die. Curious, not? While the article notes that it doesn't fully explain the paradox as most students, it is like fascinating and disturbing concept, and I really want to investigate the true magnitude of this effect, because it fundamentally impacts the validity of epidemiological data. By migrant health, you move to another country for to work, but when you return to die, where are you live? That doesn't make sense. And if a significant number of individuals are living or current health assessments for the remaining populations are artificially inflated. It's like meaning the true disease burden and the failure of the health system is being underestimated. And this will drastically alter the prioritization and design of public health interventions. Further research into return migration patterns and a specific house debt registers is essential to correct this potential bias. And give at least one specific example. In my experience or in personal professional life, as you know, I don't get a professional life because I don't work, but I'm a student of medicine, and well, I got experiences so much. And oh my god, this video we got for 10 minutes. It's so long, but it doesn't matter because this is the last one, and I want to share with you the most that I can. In my clinical rotations, I encountered a middle-aged male patient, a migrant from South Asia, who had been in the country for 18 years and was recently diagnosed with severe hypertension and type 2 diabetes. This is the most common, even when you are in cardiology. And this patient's case perfectly encapsulates the central findings of the readings: chronic diseases. And his long duration of residence, ODA, and clearly exposed him to obesogenic environment, which likely accelerated his metabolic decline. However, his most challenging issue has adherence to his medication and dietary regimen. So when his case was discussed, we learned that he faced multiple barriers: socioeconomic status, his low-wage manual labor job made following an expensive healthy diet challenging, where I was talking before, and cultural barrier, his wife who cooked, adhered strictly to traditional methods and recipes, like cooked with so much oil, which he believed were healthy, despite being high in sodium and refined carbohydrates, and low health literacy trust, like he initially took only half his medication, believing the higher dosage was a deliberate attempt by the Western doctor to make him dependent. But no, when you start a medication for diabetes or hypertension, it's the rest of your life. And this experience was a powerful human illustration of how migration-related lifestyle changes and systematic barriers conspire to create a highly complex entity burden. Because when you know a sick person, they think they just need months or even days and weeks of treatment. But with diabetes and hypertension, it's not like that. This is something that you have to do all the rest of your life, and learn to modify your dietary and your weight, so conspire to create a hidden complex. So that cannot be solved by a simple prescription. It requires a deep, culturally competent engagement with the social and behavioral context with the patient, not only with you, it's with the person that lives with you and your environment, like your wife, your sons, or your sisters, your fathers. In general conclusion, the systematic reviews and expert analysis presented this week underscore a crucial lesson in migrant health, that migration itself is a potent social determinant of health, and the national health advantage often carried by new immigrants and healthy migrant effect is systematically eroded by the host country, obesogenic environment, and structural barriers to care. So the evidence is particularly stark to non-communicable diseases. So, this is the meaning of entities that I've been talking all the video. And with obesity linked to duration of residence and diabetes showing a consistently higher earlier onset prevalence across nearly all migrant groups. So, including addressing socioeconomic barriers, adapting educational programs, and building community partnerships to ensure that equity and access are achieved for our most vulnerable and diverse populations. We don't need the best diet, we don't need the best coach, and we don't need all the money to get a good diet. It's just efforts and modify the lifestyle, because you work for another, but when you're gonna work for you, this is something that I learned with this reflection. When you're a migrant, you got a better life for you. Well, you have to take care of your health, because when you diet, nothing is for you. Everything is for the crop, the person, for your work all your life. And thanks for watching. It was a placement for me to do these video reflections every week, and trust me, I learned so much. So goodbye.